Recording in progress.
Today I'm going to take you through an introductory session through something called deep neck space infections. We'll go through a case or two and then look at how these situations present. We'll not dwell too much on the anatomy, okay? Because as we keep going, we will get into this in depth, okay? So that by the time you're in sixth year, you'll discuss something a lot more in depth than just the infections and the spaces that are usually involved. So we're just going to do deep neck space infections, and what they are is just usually collections of either bacterial, viral, fungal, or preceded by tumor that occur within the spaces of the neck. Now, the deep spaces of the neck are usually anything that is usually beyond the platysma. That is what can be classified as a deep neck space. So here we have a patient AM, who's 1 year, 3 months old, male, came in on the 21st of arrived and was discharged. Arrived on 21st, was discharged on the 24th after about 3 days. So how do these people present? The patient was presenting with difficulty in breathing and snoring for about 1 month. Okay. So what was happening with this patient? So the patient was well up to a month before, and slowly started developing a gradual difficulty in breathing that was gradual and increasing. Usually was in the night, forcing the patient to have mouth breathing, which is not normal for a child, as you know, as children are obligate nasal breathers. The child also had associated insomnia and irritability because of this difficulty in breathing. They had fevers and night sweats. There was no history of cough or contact with patients or people with tuberculosis or pulmonary tuberculosis. The patient also had the poor feeding, okay, or which we call sometimes anorexia. There was also progressive dysphagia from solids to semi-solids, and by the time they present, after a month, they can only take semi-solids. There was also weight loss because of this, and regression of milestones at the time of admission. There was no prior history of adenoid hypertrophy for the patient. The patient had been treated though for adenoid hypertrophy and an upper airway, upper respiratory tract infection with no improvement. So the thing sometimes you need to know is this is the patient's index and admission, no chronic illness. So the other history we found was uneventful, but the child was usually developing normally and was walking by 1 year and 2 months. So the child had just basically started walking. So family history is also important, okay? The patient is a second born, family of 2, father is a casual laborer, mother is a housewife, and they live in Kayole, no chronic illnesses. So on examination, what did we find? We find a patient who is in fair general condition, has a mild fever of 37.8, weighs 6.8 kilos, which is underweight. There's obvious mouth breathing. There is no stridor. The tonsils are grade 1 and grade 2 and not inflamed. Soft palate we noticed that the soft palate is pushed inferiorly by a hyperemic submucosal mass seeming to arise from the posterior pharyngeal wall on the left side. The neck is soft. There is a level 2 node that is 2 by 2 centimeters, right? That is on the left. The patient is in mild respiratory distress, is subcostal recession, intercostal recession, retrosternal recession, with transmitted sounds and auscultation, and made an impression of a retropharyngeal abscess was made. So what do you do for this patient? So for this kind of patient, what you want to do is you get a lateral soft tissue X-ray of the neck, of the retropharyngeal then what you will find is a retropharyngeal soft tissue mass and thickening. You also need to do a field hemogram because of to check the markers of infection, all right? To also check out if the patient, because of the patient has also been anorexic, do they have micronutrient deficiencies? You also need to do a renal function test, which is important for patients, especially who are anorexic, and also in respiratory failure, they also get the deranged renal functions, which will also make the situation worse. Okay, and also sometimes you can check out markers of dehydration. Then the other thing we'll do is examination under anesthesia and do an incision and drainage. So this is what we found. Okay, there was a retropharyngeal abscess, there was overlying pus, was aspirated, and 20 cc might not seem like a lot for an adult, but for a child, that is quite a bit. Okay, because you can imagine how big the 20 cc syringe is and how much it will fit in the whole oral the back of the oral cavity and the nasal cavity of the child. All right. Now, I don't know whether you'll be able to make out very well. This is the tongue. All right. This is the soft palate being raised, and this is where the swelling is. Normally, it should be sunken in a lot more than what it is there. Okay. Another view is where you can now see this hyperemic swelling at the back of the back of the palate. This palate has actually, this is the soft palate here. This is the uvula here, which has been raised, and all this is swollen and hyperemic. Same thing. So we put the patient afterwards on antibiotics. We did a microscopic culture and sensitivity, but unfortunately we were unable to get any growth because, as a member, the patient had been treated severally for previously for an upper respiratory tract infection with antibiotics, but nothing, but was not successful before, because if you do not drain anything, if you don't drain the pus, most times you will not get anything. So that was a retropharyngeal. That was a case of a retropharyngeal abscess. Okay, whereby you have pus collecting from the into the retropharyngeal space, and this space usually will come all the way from the base of skull, all the way, can go all the way into the level of T4. Okay, it is very important that you be able to drain this appropriately and quickly, because of, if it increases, you've seen how much trouble it gives the child. A child who was already 1 year has dropped to 6 kilos. All right, but it is easy to treat because you've seen after 3 days, patient was stops being febrile, becomes febrile, and is able to go home. Okay. So the second case we're going to look at is just a patient who came in on the 28th, left on the 22nd. There's a patient who stayed for a bit longer. Okay. So patient complains with referral from Meru level 5 with the 4 days difficulty in breathing. History is that this patient was well until 4 days prior to admission, when they fell from a tree, fell on a tree stump while playing and injured his neck. Okay. No history of bleeding around the neck, no hemoptysis, no hematemesis. Okay. So there's no obvious bleeding that was presented from or within the neck. So the patient developed a right side size. Okay. There was now associated difficulty in breathing, progressive dysphagia from solids to semi-solids. Okay. Remember the other child had a 1 month history of this progressive dysphagia, but this patient only has 4 days. Okay. There was also associated odonophagia. Okay. Odonophagia is pain when swallowing. So there's no history of cough and no nasal or oral symptoms. Index admission, no, nothing significant in the past medical history. Are farmers. Okay, so on examination, patient is found to be very sick looking, markedly dehydrated. Okay, there's a bruise on the neck. Okay, it is tender. It is tender, and the swelling on the right side of the neck has surgical emphysema. Okay, so you can already tell that there's something that is amiss here. All right, something has gone in and has caused a problem, or something has caused a problem that there's air leaking within the soft tissues of the neck. So the patient was in mild respiratory distress with mild stridor. The subcostal recession was present, but there were clear breath sounds bilaterally. So throat examination was essentially normal. an impression of blunt neck injury was made. Okay, now why we discussed this is because this is also another route entry of soft tissue, how you get a deep neck space infection. Okay, so in the CT scan here, you can see that you have this sort of localization, right, with a swelling around it. Normally, you should be able to see a clear airway going down to the larynx, okay, the epiglottis is up here, right? So you should be able to see a clear airway going down towards the larynx. You should be able to see, sometimes you can see an esophageal opening, but what is present here is this little darkening of air bubbles are not supposed to be present. Here you can see there's a lot of collection of air where it's not normally supposed to, where it's not normally supposed to be. Okay. So sometimes it's a bit challenging to look at the CT scan. With time, you get used to it. So I will just put this up so that at least you start getting used to having these images that you're able to be able to see and get used to having to see them. So full blood count was essentially non-remarkable. Okay. So of note is what we found when we decided to do an examination and anesthesia, and found copious amounts of pus in the hypopharynx. Remember the small image I was showing you where it was a bright whitish lesion, okay? And then the pus was found to be coming from the right parapharyngeal area, the retropharyngeal area, and an incision and drainage was done, suctioning and cleaned with copious amounts of normal saline. Now remember, these are the same deep neck space infection, but presenting in two different ways. Okay, one has come after 4 days, one has come after 3 days. So a high index of suspicion is important in dealing with this deep neck space infection. So this patient, in fact, had repeat examination under anesthesia and an incision and drainage. Okay, because they kept developing the same pharyngeal abscess, or it was not clearing as expected. Then, because sometimes you'll have to now put the patient on nilpa oral, because when you have a wound, if you're introducing food and it keeps getting trapped into the wound bed, then it will most likely give you recurrence of your infection within the deep neck space. Remember, within the neck, we're not going to suture anything, we're not going to pack, we're literally going to drain and let it, whatever is left will literally be swallowed by the patient. Those are two cases where we present with something that is exactly the same disease, but has presented in two different ways. One is post-trauma, okay, where there's an incident and then you could explain what happened thereafter, that there's an event, and thereafter there was an infection. This could either be due to an introduction of a foreign body, a laceration or injury, okay? And then you have the first one whereby you have maybe an upper respiratory tract infection that complicates, okay? So we'll go through slowly as a little introduction, okay? We'll go to a bit about the anatomy, etiology, clinical presentation, the diagnosis, and how we're going to treat some of these patients, okay? So the deep neck space infections used to have a very high mortality and morbidity, but the good thing is that the routine use of antibiotics and how we have better antibiotics now makes it a lot, has reduced the mortality greatly. In fact, retropharyngeal abscess at some point used to be a death sentence for young children. Delaying diagnosis, though, is the worst thing, because you remember what I told you, like, for example, a retropharyngeal abscess can go all the way until the level of T4. So it's going actually into the mediastinum. And once you get mediastinitis, that becomes a very difficult thing to deal with than if you were to deal with the retropharyngeal space itself, okay, or within the oral cavity or within the nasal cavity. So etiology is different for adults and children, with children being pharyngeal or tonsil infections and adults being odontogenic or salivary in origin, okay? Most common for all of them would be maybe penetrating neck injuries, getting, those of you who eat biros or pencils, getting them stuck inside the throat, or you're having a toothpick in your mouth and you swallow it, but instead of it going down your throat, it goes and lacerates your pharyngeal wall. Okay, and for some people there is just literally no identifiable reason. For example, like the baby in the first one, you're like, okay, maybe it was a respiratory tract infection, but the treatment for an upper respiratory tract infection was given, but there was no change. So the little anatomy we're going to look at is just that anything that is involved in a deep investing fascia, okay, is what we will refer to, or any space that has covered by the deep investing, anything that is beyond or I'm not going to say anterior, I'm deep to the platysma. Okay, any of those structures, you have so many spaces. You have pretracheal, prethyroid, retropharyngeal, paravertebral, prevertebral. All these spaces become spaces that are part of deep neck spaces. Even parapharyngeal region is still part of a parapharyngeal space, is still part of a. This is just a little bit about anatomy, but I'm not going to dwell so much on it. So this is what I was trying to say, that there are so many spaces that count as the deep space. Okay, so you can have the carotid space, you have the anterior compartment of the prevertebral space, you have sometimes when you go high up in the neck, you have the parapharyngeal space. All right, you have now this what we call the retropharyngeal space is usually, this is a bit lower down, but this is usually around this region. And you can see sometimes an infection on one space can easily track to another, okay, unless it's like, for example, maybe in the carotid space. But you can see the posterior cervical space is still continuous with the deep layer of the deep cervical fascia, which is posterior to the esophagus or the posterior pharyngeal wall. Okay. Infection in one, it might easily track to another, and it becomes sometimes a bit difficult to treat because in drainage, you're able to access these regions, which sometimes can be a bit difficult, especially if you're going to do if you're operating it, for example, through the mouth, or it's a pharyngeal region. Okay, if you're doing an external incision and drainage, you also have to be cognizant that this infection could track deeper into the neck than you can actually visualize. So this is just to show you the prevertebral space where our retropharyngeal abscess was forming. Okay, so you have a prevertebral division of the deep layer, you have an alar division of the deep layer, and then you have a prevertebral space, and in front of it is what we usually call the retropharyngeal space. And you can see this space tracks all the way down. Okay, now what would happen like was happening earlier in the child. So the second one is that you have infection in this space now tracking forward, okay, causing a obstruction of the laryngeal inlet, and also obstructing the esophageal inlet. Okay, in the first child, what was there was just literally what I was trying to show you was a swelling that was coming now from the behind here. It usually starts from at the top of the base of skull, coming all the way, it swells down, comes all the way towards the oral, towards like it's going towards the oral cavity, and kind of bulges as it tracks down. So the good thing about that one is literally you just make a nick at the most dependent area and let everything drain into, either you suction it, or if it's still having a bit of drainage, it will drain down into the esophagus, but it will not collect. And as long as a pus can drain, pus will go away. So these are the spaces. I would love you just to take your time when you have some free time. Well, when you have some time, go through some of these neck spaces. Okay, just get to be cognizant of what is in them. Okay, we might not grill you so much in this year and fourth year about what's in the spaces, but in your sixth year, it will become important about what is present in these spaces, because it will might give you the origin of some of these infections. Okay, here you can see the tonsil, or what you call a palatine tonsil. All right, you can see here you have your pharyngomaxillary space, which is still part of your deep neck space, believe it or not. All right. You have this, the masseter space, okay, and what is within the masseter space, usually a muscle, okay, and the mandible. So you have different spaces that also come connect to each other. So in patients, especially adults, odontogenic infections become apparent, because you see here you have a mandible, okay, and it's going to have teeth. This is the masticator space with the submaxillary space, okay, which is also which also might have a connection with the pharyngomaxillary space, and they come all the way down to the hyoid, and that's still lower down within the neck. So you can find that's might be a reason for this, and go down deeper down into the neck. This is the same thing we've just been discussing. Just want to, I would not go too much into it. Okay. So, but it's important to know that there are some spaces that involve the entire length of the neck. So, for example, the retropharyngeal space, the danger space, the prevertebral space, the visceral vascular space, which is basically the carotid sheath and whatever is within the contents within it. Okay. The good thing about the spaces that are limited by the hyoid, it also gives you a good landmark about how the infection is. If you see an infection that now, this is the regions that the lesions that are, these are the spaces that are more likely to be involved. Okay. The spaces that occur now below the hyoid bone are usually few. Okay. And they're rarely usually infected unless by direct trauma or direct inoculation. But the spaces that are very dangerous, or the prevertebral, the retropharyngeal space, the danger space, okay, and the prevertebral space are usually very risky. The visceral vascular space, you will not always find infections in the carotid sheath because it's well capped. It's a very tight sheath. It doesn't communicate with anything unless you're getting thrombi of infective thrombi from the brain. Okay. So look at the retropharyngeal space, because we've discussed it twice, okay? So it has an anterior, posterior, and lateral walls, extends all the way to T2, okay? Some people, it extends all the way to T4, okay? Divided into right and left spaces by a median raphe, but that doesn't always hold, okay? It's usually a very thin raphe, so sometimes when you get an infection, it'll be more on one side, yes, but it still tracks to the other side. And also most times contains nodes which now get infected and become the source of for you developing your abscess. Now, in adults, usually the most common reason for having a retropharyngeal space infection, like I said, is usually instrumentation or trauma. But remember, when in the beginning, when we were asking about TB, TB was one of the things that used to give a lot of our patients now within our context, a lot of TB spine, or giving children retropharyngeal abscesses. Okay, so it's always important to rule that out. TB, as much as nowadays we're doing better, it's not as common as it used to be. Okay, like when I started training, as in terms of seeing TB, ENT manifestations or abscess manifestations of TB are not as common because we have better treatment now, but it's something you need to be watchful for, especially in a patient who has a long history or progressively long history of symptomatology that would lead you to think that maybe they have a deep neck space infection. Okay. Yeah. So the parapharyngeal space is also an important space. Okay. Remember, this one is limited usually by the hyoid, but it is important because it contains a lot of stuff within it, and it usually has two components. And what's important about it
Dr. Ngugi? Recording stopped.
Hello, I seem to have lost the connection. Where was I before I got cut off?
Dr. Ngugi.
Yes, where was I before I got? I don't know.
We had just finished talking about the retropharyngeal space.
Oh, okay. So I can be allowed to share the screen as we continue with the parapharyngeal space.
Yes, please.
Okay. Can you allow me to share screen? Oh yeah, thank you.
Yeah.
Recording in progress.
So, like I was saying about the parapharyngeal space, this is divided into two components usually by the stylo process and the stylomandibular ligament. Okay. The good thing about it is that it really has an acute infection, but it is has a lot of stuff in it, from parotid tissue. You have the tail of the parotid, you have lymph nodes, you have nerves and blood vessels. Okay, so it can form the basis of either many tumors or many infections, cold infections occurring within there. So if you have maybe a parotitis or siloadenitis, okay, causing enlarging tissues and infection of parotid tissue, you get it in there. It has large lymph nodes where you can actually get abscesses within the parapharyngeal space. And if you ever find a patient with a parapharyngeal abscess, okay, suspect that this patient has an element of immunosuppression until you can prove otherwise. Okay, it's usually one of the markers of patients who have been maybe on ARVs or not have stopped taking, or are unknown to have retroviral disease or immunosuppression due to either lifestyle. Maybe they live well, they eat well, they take care of themselves, regularly exercise, but they all of a sudden they get these opportunistic infections. Okay, so they also suspect involvement if a patient has trismus. So usually you have medial pterygoid muscle spasms because of an infection in this region. So patients usually tend to drool. They have dysphagia, but usually no pain on swallowing, so there's no odonophagia. They tend to talk with a hot potato voice, because they literally is going to affect the pharyngeal speech. Unlike the retropharyngeal abscess, which pushes forward, parapharyngeal will tend to push medially and also laterally. All right. So here you can see part of the parapharyngeal, the contents of the parapharyngeal space. So you can see you have your cranial nerve number 10, number 11. You have number 12 as well. Okay. You have the stylophyllangeus muscle. Okay. So you have parts of the parotid gland, usually the tail, usually within this space. Okay. So it's important to note, because you see what's happened. If this is the palatine tonsil, so what's going to happen is that if there's an abscess in this area, it's going to push immediately. But sometimes if you have an abscess within the parotid tissue, it might push also externally or laterally. So how do these patients present? So there are many other spaces, but those are the two most common, and those two I want you to think about at this point in your training. And then later on, we'll talk about the others as you come to 60 hours, and also as you rotate within the department. So retropharyngeal abscesses, the good thing is that you usually has a lot of symptoms, and you need to have a high index of suspicion, though, because the patient is like anybody, will present like any other maybe upper respiratory tract infection, fever, irritability, poor oral intake, dysphagia, drooling. Neck stiffness will occur, but you have to be very careful about that, because you want to make sure. That's why we do two examinations for, especially for meningitis. So if you just have one, you need to be suspicious. Why is this patient having just one part of neck stiffness, or has normal mentation but has neck stiffness? Okay. The lateral bulge on the posterior pharyngeal wall is something you need. So all these patients, you must always look into their mouths. Okay. Even if you're suspecting a parapharyngeal abscess, remember, you must look in the mouth to see either posterior bulge or a medial bulge. Okay. Sore throat, laryngeal edema can occur in later disease, or when the disease is more aggressive. Remember, this is the image I showed you before. So you can see that posterior bulge. Okay. You can see this posterior bulge. It has almost like it's pointing. Okay. This is the uvula. For point of reference, this is your uvula. We have raised the soft palate up. This is your palatine tonsil. Okay. You can see this is your posterior arch. So this is not supposed to be like this. It's supposed to be a depressed area, smooth and pale pink. So this is the color you want. This like pale light pink is what is supposed to be here, but you can see here it's totally erythematous. Now, clinical presentation for parapharyngeal abscess will depend on whether it's pre-styloid or post-styloid, okay? Because post-styloid usually is on the outer, tends to be on the outer segment or more lateral, whereas the pre-styloid tends to be a bit more medial, okay? So hence why you get a slight difference in presentation, and also the contents of those regions will differ. Hence why you'll also get, like in post-styloid, you get cranial neuropathies, you get Horner syndrome. You can get in IJV is internal jugular vein thrombosis, carotid artery rupture because of infection. Okay, it's not very common, but it's very devastating when you do get it. But if you're good, a high index of suspicion, you'll be able to pick them up, and they're easy also to deal with. So there's a danger space. And why is it called the danger space? And I wanted to remove this slide so that somebody can ask what the danger space is, because I mentioned it and I didn't say anything about it. Okay, this is the inferior. It's the inferior border. Its inferior border is continuous with the mediastinum, vena cava, thoracic duct. So it's usually just anterior to the retropharyngeal space. Okay. The reason why it's dangerous is, as seen here, you have erosion of major vessels. It can go to the lower airway and aerodigestive tract, and if not treated quickly, will lead to death of the patient. So plain X-rays are very good. They are the things we do, especially for the children when you're suspecting retropharyngeal abscesses. Okay, so nowadays you've gotten a lot better. There's digital, so where you can zoom in and get good clarity on the image, whereas the other one needs to be a one static film. Okay, so what you're looking at is the width of the vertebral, the prevertebral tissue, and if you see it is more than this, what I'll put there, more than 7 at C2, more than 14 at C6 in children, or more than 22 in any adult, then you become suspicious that there is something going on in there. You will not be able to tell whether it is in the prevertebral space. You will not be able to tell whether it is in the danger space or the retropharyngeal space. But the treatment is the same. If you just put your blade there and drain that pus, then you'll have dealt with that infection. Okay. Here you can clearly see this huge swelling that's right here. Okay. This huge swelling now is what is most likely this is what the retropharyngeal abscess will look like. Okay, so usually what we do is just make a nick and make an incision just straight down to allow this pus to drain. We suction out as much as we can. We make an incision. We try to make an incision as don't want to make it too long, but you also want to make it at the most dependent area. So like for this child, we'd open the mouth like with the same mouth gag and go slightly lower and just make a long incision, let all that pus drain out or suction it out. CT scans also good. Oh, sorry. CT scans also good. Sorry, 1 moment. CT scans also good, but usually it's the modality of choice for when you're doing for parapharyngeal infection. Ultrasound can be used for image-guided aspiration. For example, if you have patients who are very sickly, patients who are unable to tolerate theater, okay, you can be able to drain some of these abscesses, apart from the retropharyngeal abscess, which literally just open the mouth and just make an incision. MRI is important for if you're suspecting maybe this tumor that is causing repeated infections, okay? And it's the best for soft tissue delineation, okay? So organisms involved, usually polymicrobial, you have the streptococci and anaerobes, okay? Others commonly involved is an anaerobic streptococci, H. influenza, Moraxella catarrhalis, Klebsiella, okay? For the retropharyngeal abscess, usually strep and staph usually are common. Because of the immunizations, H. influenza and M. catarrhalis have kind of gone down in their presentation or their epidemiology of this situation. So what are we aiming to do when we're trying to treat this patient? We want to make sure we protect our airway as much as possible, as that's the most important, because if the patient can't breathe, there is no patient, okay? Antibiotic therapy is usually recommended, but this one usually is supposed to follow after surgical drainage. When these infections are small, some people attempt, but on the deep neck spaces that are more on the external neck, I mean, on the ones that are present on the external neck, you can give antibiotic therapy. But surgical drainage is the gold standard for any deep neck space infection. If you can put a blade to it and drain that pus, then you'll have helped that patient. So how do we secure the airway? 1 moment, sorry. How do we secure the airway? We secure the airway usually by either putting an endotracheal tube or a tracheostomy tube, okay? But as you see, endotracheal tube has its own limitations, okay? But we need to be aware and cognizant of. So these are just basically precautions for when you're taking an intubation. You must make sure that you can see well. Sorry about that. You must make sure that you can be able to see well. You're doing the correct. You have the correct. You're able to suction off the pus in case it ruptures, the abscess ruptures. You have the correct size of the tracheal tube. You're using a stylet so that you can be able to intubate quickly and safely. So you're not instrumenting many times, and you must always be ready for a tracheostomy because this can go bad really fast. So treatment of choice usually empirically we give amoxicillin clavulanic acid and flagyl. And give third generation cephalosporins and clindamycin. All right. Like you remember, our first patient improved in 3 days. Okay, you could see the first day they already are febrile, second day they were doing well, and then the third day they went home. If you don't get that, or you don't get a patient who's improving, then you must do country image, see if there's any recollection. Okay, and then you can also alter antibiotics. For example, if you find been putting the patient for over 3 days with amoxicillin clavulanic acid and flagyl, and there's been no response, then you step to the second line. So surgical drainage, like I've said, is our mainstay for treatment, because you have once you drain the pus, patients tend to do better, and you get better penetration of your antibiotics. Okay. So, like you've seen, this abscess can spread low. So you might find that you might have to do an internal transoral approach and also do an external thoracotomy for some of these patients, or even external approach if you can't access transoral through the parapharyngeal space. But this is usually not, it's rarely done. Usually transoral we can be able to do a good transoral all the way until the cricopharyngeal, so the opening of the esophagus. Okay, and then they'll have the cardiothoracic team now come in and do the external thoracotomy. Parapharyngeal usually can be drained externally. All right. It can also be drained internally. As much as I wrote, very rare, but sometimes it's done. But most times you will not. You might end up having to redo, or especially if a patient. These are patients where you show it's an abscess and you're sure it's. For example, in guys who have retroviral disease or have immunosuppression, and you know they're going to have repeated surgeries, you can go through the transoral approach because orally you heal very well. So usually, most times, just put a little blade inside and suction all that pass out. The best would be to remove the capsule, but sometimes you are unable to do that transorally. Okay, that's why even interventional radiology can come in, help you drain it, and because you know they're going to come back again and do it again, so you have less trauma and less instrumentation on the patient. So the complications are usually the problems with the deep neck space infection. Mediastinitis will take you down very fast. So as carotid erosion and hemorrhage, those ones are almost a death sentence if they do happen. Okay. Cavernous sinus thrombosis is a very difficult thing to treat. Okay. Horner syndrome, cranial nerve pulses. This one's a good thing is that they tend to resolve once if you give good antibiotics and when you drain the pus. Osteomyelitis also takes long to treat, especially of the spine. Aspiration and sepsis are also part of the complications. Thank you very much. That is the end of my presentation. If there are any questions, please let me know. Somebody is asking about the danger space. One moment. So the danger space is this is the danger space. Okay. So it is literally behind part of the retropharyngeal. It's slightly posterior to the retropharyngeal, but anterior to the prevertebral. But it keeps going down. Remember the prevertebral. The prevertebral space is actually divided into two. One part that ends part in T2, together with the retropharyngeal space, and then you have another space that now goes further down. Okay. So now the problem about this is because it goes into the media, it also invests into mediastinal, the mediastinal spaces and giving mediastinitis. Sometimes it's very important to be able to pick this out, have a high index. Any other questions? All right, if there are no other questions, and I think we can call it a day. Thank you very much.
Thank you.
Thank you.